So my response to the question, do we need to start with chemotherapy for optimal frontline therapy for follicular lymphoma, is no. And Richard and I have been having this debate for now about 12 years. And for 11 of those years, every Tuesday, we actually would, probably about 2 or 3 times a month, rekindle the debate as patients were being presented. And I haven't changed his mind in 11 years, so the thought of changing anybody's mind in this room in 20 minutes is a challenge. But I thought that there's another way to look at some different data sets. And really, I think the important concept is when you ask the question, should patients' first-line treatment be chemotherapy, is to appreciate that follicular lymphoma is a very heterogeneous disease. There's certainly subsets of patients who need chemotherapy. I would actually suggest that I believe the majority of patients probably don't. And there is plenty of evidence as to how heterogeneous follicular lymphoma is. You can look at clinical prognostic scoring systems like the FL-IPI and identify a group of patients with low-risk disease who have a 5-year overall survival of 91%, and another group who have high-risk disease with a 5-year overall survival of 53%. Seems that we might be able to make some different treatment choices for those groups of patients. Similarly, we know, looking at gene expression profiling, that the biology of the disease can certainly be heterogeneous. And a group of patients with this particular gene expression profile that's really based on the microenvironment from T cells and macrophages has a very favorable outcome with overall survival of more than 10 years. And another group of patients with a different signature can be identified with a very unfavorable outcome. So just keep that in mind as we go through the data sets rather than putting everything together. I think the other question before we get into some of the trials is, what is the aim of therapy in an incurable disease like follicular lymphoma? And the FDA and most of us in this room would say that we want patients to derive clinical benefit. And what defines clinical benefit? Well, the first would be symptom relief. They feel better. I will say that most of my patients with follicular lymphoma are not symptomatic, and I've had some patients who for 10 years the only symptoms that they've had are the symptoms we give them with treatment. The lymph nodes don't hurt, they don't get B symptoms, and so forth. Another reason why you might treat or get clinical benefit is if you improve quality of life. So certainly there's some physical examples of that. You might decrease transfusions, decrease infections, and so forth. There's also the concept of psychological. Patients feel better if they're in remission. I would actually suggest that we don't really know if that's true, and if you educate patients appropriately, that may not be the case. And I've had certainly some of my patients where the first 6 months is spent trying to convince them that they don't need treatment, and then 3 years later, when they really need treatment, it's just as hard of an argument to say, actually, now we need to treat you, and they want to put it off for as long as possible. So, although that argument's been made, I think we need data to really defend that. And I think ultimately, and this is what Richard, I think, was trying to get at, is the reason to intervene is if you can change the natural history of the disease. And really, the best measurements that we have to change the natural history of the disease would be if you could decrease transformation. That's probably a surrogate for poor outcome. Certainly if you could improve overall survival with an initial treatment regimen. Or if you could delay the need for toxic therapy. If you said that you don't need a bone marrow transplant if I treat you now, that would clearly be a reason to intervene. So it's because of the heterogeneity that people put up slides like this. And I would just remind you that there are a large group of patients who present with advanced stage disease and low tumor burden, where observation has historically at least been the way that these patients are approached. And the reason why that was the case is that there have been studies in the past of asymptomatic, advanced stage, low-grade lymphoma that found no difference in overall survival between immediate chemotherapy with, albeit an inferior regimen of chlorambucil, versus delay of treatment until progression. And in fact, clearly the toxicity was higher in the group of patients who got early treatment. A more recent randomized trial actually looked at different approaches from chemotherapy in these low tumor burden patients. This was initially a 3-arm study of either observation rituximab for 4 weeks, or rituximab for 4 weeks followed by a maintenance of rituximab. No chemotherapy in any of these arms. Arm B was closed early. And the bottom line is that the rituximab-containing arms had improved progression-free survival. There was no difference in overall survival. Quality of life was actually no worse in any of these arms. But the progression-free survival here in Arm C was 80% at follow-up, and that's without any chemotherapy at all. And we looked at this in the National Lymphocare study, and you can see that in this group of patients who were observed compared to an active therapy group, there were some differences between these patients in the registry. As you might expect, patients treated with active treatment were more likely to have high-risk disease and more likely to have higher grade follicular lymphoma. But the bottom line is that there's no difference in overall survival in this modern era, at least in this registry experience, based on treatment in the frontline setting, suggesting whether you observe somebody, treat them initially with rituximab alone, or chemotherapy, really the overall survival is the same. And some of this may really be more about sequence than optimal choice at the beginning. I think another informative data set that does have long-term follow-up now is this data set from Switzerland, where patients with both a newly diagnosed and relapsed indolent lymphoma received 4 doses of rituximab and then were randomized to either observation or 4 additional doses of rituximab. And what this showed initially was a benefit as far as event-free survival with the prolonged rituximab dosing. And that's not a surprise. And the question is, why am I showing this data? But because with 10-year follow-up now, 25% of these patients in the 8 doses of rituximab group remain in remission at 8 years. And in fact, if you just look at the chemotherapy naive patients, in other words, the newly diagnosed patients that are germane to our discussion today, 45% of these patients remain in remission at 8 years. Now, this was a relatively small group of patients, but it's hard to argue that these patients would have really benefited from chemotherapy and rituximab 8 years ago. And this is a way that we've saved this group of patients the toxicity, and they still have very favorable outcome in the 8 to 10 year range. And you could look at a curve like this and wonder if maybe the rituximab has cured some of these patients. I doubt that's the case, but clearly if they progress, you might be able to intervene with non-chemotherapy again and save them chemotherapy. Overall survival was very favorable for all of these patients, and in fact similar to what you'd expect with some of the higher tumor burden patients who were treated with chemotherapy. The RESORT trial is another data set in this group of patients, and this is again the most common presentation of follicular lymphoma, advanced stage disease, and low tumor burden. Again, similar to the other study, all patients got rituximab initially, and then were randomized to either scheduled maintenance or rituximab retreatment at progression. And the question was really, how long could you keep chemotherapy away from these patients? And the primary endpoint demonstrated that whether you got retreatment or maintenance, you can see that many of these patients could go for years without requiring any chemotherapy at all. And in fact, here's really this curve. The time to first cytotoxic therapy looked a little bit better in the group who got maintenance, but 90% of patients did not require any cytotoxic therapy in this study for the first 5 years after diagnosis. So you have all of these patients that went into this study, hundreds of patients. Only 10% of them actually needed chemotherapy in the first 5 years using this rituximab strategy. Again, it's really hard for me to argue that giving them R-CHOP 5 years ago would have resulted in any better outcome. So let's just show one other data set here from Italy. This is more recently presented, and Eva Kimby sent me these slides. Again, this was another study that was a little bit more complicated, but it has the same message. 2 different versions of rituximab, either with or without interferon, and then there was a maintenance component, but again, no chemotherapy. And you can see that the overall survival is incredibly high without any chemotherapy at all. And in fact, if you look at time to treatment failure, this was a higher tumor burden group of patients. There were still a large number of patients years out that did not require any cytotoxic therapy. So I would say many patients with follicular lymphoma do not require chemotherapy. And two different approaches that you might consider instead are watch and wait, where there is no overall survival benefit that's ever been demonstrated with early treatment, and no change in transformation has been demonstrated with early treatment. And Rituximab, as another option, has a highly active therapy in a variety of schedules, and long responses have been observed with really outstanding overall survival. And finally, I'll just say that the future, looking ahead, might be this combination of lenalidomide and Rituximab, that a 3-year progression-free survival in a group of probably low tumor burden, mainly patients from MD Anderson, suggested an 81% 3-year progression-free survival, which is at least equivalent to what's been observed with chemotherapy. And that's led to this important randomized trial that will be one of the first to really answer this question long-term, where half of the patients are getting R-squared or lenalidomide and Rituximab, no chemotherapy, and the other half of patients are getting Rituximab plus your choice of chemotherapy. And the fact that this study is accruing would suggest that there's reasonable equipoise among most of the physicians here, and that the question is, what's the standard here? And at least I think looking forward, we're all trying to avoid chemotherapy. So I'd like to thank the ability to at least express my opinion on this, and I trust that in another few years we'll still be having this debate, so I don't expect much will be settled today, but thank you very much.